Good afternoon, everyone. My name is Marissa Gomez Garcia, and I work in the Community Engagement and Education Division at the Michigan Department of Civil Rights. I will be your moderator this afternoon. For full accessibility today, it is important that speakers first identify themselves by name before speaking and mute their microphones after they are done speaking. We have ASL interpreters on screen, and live card captioning is available by turning on your subtitles using the CC icon on the lower part of the screen. We will have a question and answer section during today's session, and attendees can use the Q&A function on the lower part of the screen to type in questions for our presenters at any time. With that said, it is with great delight that I welcome you to this month's installment of our 2023 Michigan, spelled MI, Response to Hate virtual campaign forums. We will have a new installment every month through September, by which time the campaign will culminate with our annual Michigan Response to Hate conference. The spirit of the campaign was captured by our team through the development of the public service announcement, which is to follow. Please watch.
Race is the #1 motivating factor for hate crimes in the United States.
Did you know that hate crimes against Asian Americans have increased by over 73% since 2019?
Did you know that there are state and federal laws that protect you against hate crimes and bias incidents?
The Michigan Department of Civil Rights and the Michigan Alliance Against Hate Crimes have launched the My Response to Hate campaign to inform Michiganders of hate crimes and bias incidents occurring in Michigan.
You can take action in your own way by showing love, not hate.
If you see something, say something.
Support victims. Report the incident.
Make a commitment.
My response to hate.
My response to hate.
My response to hate.
My response to hate is love.
Visit michigan.gov/MDCR for more information on hate crimes, bias incidents, and available resources.
It is our hope that the campaign will provide you with information pertaining to hate and bias prevention that you can implement and use in your daily lives, at your workplaces, in your schools, and in your communities. So without further ado, we're going to jump right into today's topic. Today's theme is focused on eliminating hate or bias in healthcare. We have a couple of dynamic presenters lined up for you today who have dedicated their professional careers to public health and the health center movement. They will lead us in a discussion on how to reduce health disparities and improve health outcomes. We are very excited to welcome our first presenter, who will discuss the role of bias in birthing and maternal health. Please join me in welcoming Danielle Calloway. She is a health equity project coordinator in the Office of Equity and Minority Health within the Office of Race, Equity, and Inclusion at the Michigan Department of Health and Human Services. She brings a wide wealth of knowledge in public health, which includes almost a decade of maternal child health and health disparities research and community work. She has experience leading projects focused on community health assessment and planning, maternal child health, Native health, and mental health. She brings experience spanning the gamut and is familiar with many project management details, including evaluation planning, facilitation, data analysis and interpretation, and report writing. Her areas of expertise include qualitative and quantitative data analysis and community-based research designed with an equity lens. Community engagement and service are core to Ms. Calloway's interests. She is a prior AmeriCorps member who served Lansing area residents through food security projects. Her other passions include birthing and reproductive justice, and systems change as a way to address upstream factors limiting the health and well-being of vulnerable populations. Ms. Calloway, the floor is now yours.
This is Danielle Calloway speaking. Hi, everyone. I am going to share my screen. I have a brief presentation for you all today that will cover the impact of bias in birthing and maternal health. As mentioned, my name is Danielle Calloway. I am a health equity project coordinator within the Michigan Department of Health and Human Services, specifically within the Office of Equity and Minority Health that sits within the Office of Race, Equity, and Inclusion. Our conversation today, our agenda will cover some overall level setting definitions so that we are all on the same page. Talk about the impacts of race and bias on birthing and maternal health, and then steps to addressing disparities and improving outcomes. First, we're going to cover level setting definitions. So the first one is just maternal health. So maternal health focuses on the well-being and care of an individual during pregnancy, childbirth, and postnatal or post-delivery period. This care can be focused on family planning, pre-conception care, so those well women visits that happen before a pregnancy occurs, prenatal care that folks receive during their pregnancy, and then postnatal care, so the follow-up appointments that folks will receive after delivering. The next set of definitions are covering some of the aspects that impact folks that are delivering children. So that is infant and maternal mortality. So maternal mortality refers to the maternal deaths that occur during a pregnancy or within the first year of pregnancy. That can be broken into pregnancy-associated, pregnancy-related mortalities. Pregnancy-associated mortality has to do with a death while pregnant or within 1 year of pregnancy. This can include pregnancy-related, pregnancy-associated, or not related deaths. So the where pregnancy-relatedness was unable to determine. So this really is for anyone who may have been pregnant or recently completed a pregnancy within that first year. Any of those folks who've experienced a death. And then you have pregnancy-related mortality. Those are the death or passing while pregnant or within 1 year of the end of a pregnancy from any cause related to or aggravated by pregnancy and its management. So pregnancy-related mortalities usually are factors that are tied to their condition of being pregnant or aggravated during the pregnancy. This can be things like cardiovascular conditions, such as hypertension, cardiomyopathy. They can look like pulmonary or thrombotic embolisms, as well as substance use or misuse that may have occurred. And lastly, wanted to define infant mortality for folks. So that is the passing of an infant that might occur between birth and the age of 1, so prior to their first birthday. What is equity? So equity, we often talk about equality and equity. So equality is everyone gets the same treatment, plan, tools, resources, whereas equity is allowing for those resources, tools to be provided to everyone with the understanding of the barriers and circumstances that you may see within their condition. Specifically, when we talk about health equity, we're talking about the state in which everyone has a fair and just opportunity to attain their highest level of health. Achieving this requires some societal efforts, such as addressing historical and contemporary injustices, overcoming economic and social, as well as other obstacles to health and health care, and eliminating preventative health disparities. For folks who may like to see a graphic that's associated with equity and equality differences, in the top right corner of your screen, you'll see two images. The equality image covers folks who all have bicycles but have kind of different conditions that may prevent them from riding the same size bicycle. So we have some folks who use assistive devices such as wheelchairs, some that are maybe a bit taller. And then lastly, we have an individual who's a bit shorter than maybe this bicycle will accommodate. So we see that everyone does have a bike, but not everyone is able to ride it to their fullest extent. Whereas that equity image right below shows various adaptations that were made to the bicycle, whether that was assistive devices or a different size of bike to accommodate various folks. And that's just one example of how we can look at the differences of equality and equity in our everyday lives. One of the factors that can impact our barriers and the experiences that we have with achieving equity is race. So I wanted to also define race. What is race? Race is a social construct, a way to sort people into groups based on perceived physical and behavioral characteristics. Race is not biological. There's no clear definitive link between race and biology. Sorting people into groups and of itself doesn't have to be a negative thing. Grouping by physical characteristics, however, can be problematic for those groups are tied to preferential treatment because those ties are arbitrary. So you may be thinking, what is the significance? Why does race matter? We see from the past president of APHA, the American Public Health Association, Kamara Phyllis-Jones mentions that racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which we call race. This is unfairly disadvantaged some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. So it kind of touches on naming specifically that preferential treatment I mentioned on the prior page. Racism is the clear naming of how those certain folks receive different treatment and how that can really start to impact others. As we know, now we see more statements highlighting racism is a public health crisis. So the public health impact of racism. Racism shapes both opportunity and access to resources that support health. This also contributes to growing health disparities between and across communities. For example, within the US, up to a 7-year difference in life expectancy exists between racial and ethnic populations. When we look across economic status, Black women are 3 times more likely than white women to die within 1 year of childbirth. When we look at Black American, Indian, or Alaskan Native and Hispanic Americans all have a COVID-19 death rate that is nearly triple that of white Americans. So there we kind of get to see some of the health impacts that the differences in treatment can have on folks. And there is a term for the strain and the weathering that folks experience. So weathering describes how the strain from coping through chronic stress and structural and interpersonal racism and bias over time causes a physiological change. The result is accelerated aging, increased risk of chronic disease, and other adverse health outcomes, including premature death. So for those who may have wanted to look for a term that describes the impact of bias, impact of hate or preferential treatment, I highly recommend looking more at some of the theories behind weathering. It really goes into detail a bit of how long-term negative experiences in day-to-day can add to our stress level and impact our overall health. Across the top here, we have racism is a public health crisis. What if we responded to it like we would have COVID-19? So when we look at the public health impact of racism in terms of economic pieces, we see that health disparities have cost the US an estimated $60 billion in excess medical costs, $22 billion in lost productivity in 2009. And that burden in excess medical costs is expected to increase. When this study came out, they projected it to be 126 billion in 2020 and 363 billion by 2025. So not only is it impacting our overall health outcomes and our longevity, but it is taking an overall toll on the greater health system. According to the American Public Health Association, over 250 declarations of racism as a public health crisis have passed in 37 states. We're starting to really see this conversation come up more and more, the impact that race has in your overall health. Impacts on birthing and maternal health outcomes. So now that we've talked a bit about the role of race, let's talk about some of the impacts directly tied to birthing and maternal health outcomes. The biggest one is going to be that maternal mortality. So when we look at pregnancy associated but not related mortality, so those would be factors that are not tied to pregnancy at all, such as domestic violence, car accidents, various things that are not related specifically to the pregnancy or not aggravated by one being pregnant. So when it comes to that, we see a 1.8 times increase in the rate of American Indian or Native American birthing persons in their maternal mortality rate compared to that of white birthing persons. When we look at Black birthing persons, they experience a 1.6 times more likely rate of pregnancy-associated, not related mortality as compared to white birthing persons. And then specifically looking at the pregnancy-related causes of mortality, we see that Black women were 2.8 times more likely to die of pregnancy-related causes than white non-Hispanic women. And this data is all specific to Michigan. So these are the experiences of the folks that we serve at the state and throughout the state of Michigan who may experience a pregnancy. And all of this data has been gathered by the Maternal Mortality Surveillance Committee. They take the time to look at these causes of death and kind of convert them into numbers and risks. Some of the factors impacting maternal mortality. So it is due to the experiences of bias, discrimination, and structural racism that we see these increased rates of maternal mortality among Black non-Hispanic persons, as well as American Indian, Native American persons. Let's discuss the impacts of our social factors and the roles they can play in accessing care, patient-provider relationships, and the overall well-being of birthing persons and their infants. Many of you may have seen the social determinants of health before. There is the image from the CDC on the right-hand side. That is a vibrant circle that provides a section of 5 sections of a pie covering each of the social determinants categories. So healthcare access and quality, neighborhood and built environment, social and community context, economic stability, education access and quality. So I want to talk a bit about disparities and the role of social determinants. Economic stability. Racial and ethnic minorities often experience discriminatory hiring practices and may struggle to achieve career advancement. Career opportunities are one of the key pieces that allow us to access high quality healthcare insurance, as well as provide the economic stability to afford associated medications for some of those pregnancy-related causes of death, such as cardiovascular conditions, hypertension, genetic changes that folks may have been born with. So having a lack of economic stability as a minority may put you at a vulnerable position for disadvantage. Education access and quality. Racial and ethnic minority students are more likely to be subject to abuse, degrading disciplinary tactics ranging from over-policing to corporal punishment. They are less likely to be in well-funded, well-resourced schools offering advanced classes. The lack of well-funded schools, well-resourced schools really puts folks at a major disadvantage of having that educational head start, to have a deeper understanding of health, have a deeper understanding of birthing, pregnancy, and all of the factors that go into that in terms of the significance of prenatal care, the significance of prenatal vitamins, taking care of your body, and some of those ties around preeclampsia, for example, and its impacts on making a pregnancy more high risk for folks. This next slide continues our talk on disparities and the role of social determinants. So to talk about healthcare access and quality, Racial and ethnic minorities experience barriers to trauma such as stigma, mistrust, and discrimination. Often members of these groups receive poor or culturally incompetent care. I'm sure many folks have had maybe a not so great experience with a healthcare provider before, but when we look specifically at those who are a racial or ethnic minority, those negative experiences are not uncommon. They are not one of a dozen. They tend to be the norm for them, unfortunately. And through those negative experiences, studies have shown that folks are less likely to continue to seek out medical care, less likely to adhere to medical care plans, and overall less likely to even pursue traditional healthcare providers as a resource during a medical crisis. And all of those factors culminate in the impacts that they will have on your overall health and your overall longevity, especially when you are pregnant and planning to become pregnant, that you really need to have that strong relationship with the healthcare provider. Social and community context. So frequent presence of stress hormones can lead to physical conditions like high blood pressure, heart disease, as well as mental health conditions like depression, anxiety, and overall poor health outcomes. I think this piece ties in some of the other determinants or factors that we've talked about today. Throughout many of these challenges and barriers in terms of economics, opportunities, high quality education, quality and respectful healthcare provider interactions, those all are very low likelihood for those who are within racial and ethnic minorities. That in itself can cause a high culmination of stress, really exacerbating the weathering that I talked about a bit earlier. And that can show up in both physical as well as mental conditions. So it's always important to manage your stress and not kind of avoid taking care of your overall conditions. So the last disparity and role of social determinants that I want to talk about is neighborhood and built environment. So there is an image on the right-hand side of the screen that depicts the Detroit area. And as you may see, these various colors on the screen that are in different regions or districts of the area. So we have red, yellow, blue, green. These all are kind of representations of where folks are residing in the city based on their racial and ethnic identity, as well as it shows a history of how folks have been able to purchase and access property within the greater Detroit area. So I will talk a bit about neighborhood and built environment. So inequities in housing, such as access, costs, sustainability, and location, do far more to predict health than the impacts of personal choices and health behaviors. Some factors contributing to the place-based racial history of built environment. So there is this long history that has led to the very colorful subsections that you're seeing dividing up this map into puzzle pieces. And those are restrictive covenants or processes of placing a clause in the deed or lease to the property that limits what the owner of the land or lease can do with the property. Redlining, or the systematic denial of mortgages, insurance, loan, and other financial services for individuals or residents of certain areas on race or ethnicity. Gentrification has been shown to influence both the eviction and homelessness rates, as well as the social capital minority groups. The underwriting manual of the Federal Housing Administrative in the 1960s recommended that highways would be a good way to separate African American neighborhoods from white neighborhoods. And we've seen this discussion come up specifically in the Detroit area with their readdressing of their 375 freeway, which was put in place over a series of neighborhoods and is now being converted to a boulevard to kind of decrease their road presence and potentially add additional stores. But that's one Michigan specific example of the Federal Housing Administrative Act there. I want to just take a couple minutes here to talk about efforts to address disparities. So these are some of the activities that are happening across the state of Michigan to kind of touch on the disparities and structural pieces that we're seeing here. We have the Maternal Infant Health Equity Improvement Plan, also known as the MIHEIP, M-I-H-E-I-P. And so this plan works to develop a plan that outlines a basic holistic approach to supporting the health and well-being of birthing parents and their babies through addressing gaps. This focuses on specific priorities. Those priorities are health equity, healthy girls, women and mothers, optimal birth spacing, full-term healthy weight babies, infants safely sleeping, and a mental, emotional, and behavioral well-being. Some brief highlights of the MIHEIP plan is they recently released their 2021 Health Equity Report, focused on moving health equity forward. Annually, the plan has space for the Maternal Infant Health Summit that is occurring this week in Lansing. And it also kind of passed the Maternal Infant Health Action Committees. And so these committees work to provide recommendations around funding and policy priorities for the state of Michigan. It also allocate some responsibilities to the Michigan Maternal Mortality Surveillance and Fetal Infant Mortality Review Committees. These groups work together to improve services and resources, either for the families and birthing persons who may have experienced a loss, as well as looking deeper at some of those causes and how we can work to address some of those. One of the bigger highlights is the expanded Medicaid coverage that we had in these recent years to expand coverage for those after giving delivery for a full 12 months. We additionally have our regional perinatal quality improvement collaboratives, quality collaboratives in Michigan. And so Michigan has 9 what are called RPQCs, Regional Perinatal Quality Collaboratives, to represent each of the prosperity regions. So I provided a map of the state of Michigan on the right here that depicts each of the prosperity regions, giving them each their own unique color. There are 9 RPQCs, but there are 10 regions, our prosperity regions. That is because 2 and 3 work together to form one regional perinatal quality collaborative. They focus on building partnership with community leaders and organizations to address the major regional needs, look at ways to improve birth outcomes for birthing persons, infants, and families, and engage families and community members as experts to advise and provide recommendations. So they have kind of really touched on 3 key pieces throughout this last couple years, and primarily doing some community vaccination and outreach specific for COVID-19. And regions have taken that in various ways, whether that was art contests, testimonial videos, or some mini granting specific to outreach groups, working on implementation of health equity focused efforts. So that was universal home visiting, centering pregnancy, which is a way of supporting folks who are pregnant throughout their pregnancy journey, and then a resource library and data dashboard. Lastly, perinatal quality collaboratives have focused on perinatal substance use disorder supports and resources. So the use of screening tools such as high touch, high tech, as well as looking at ways to make medication assisted treatment more accessible for folks. We have the Michigan Alliance for Innovation in Maternal Health. And so this is a quality improvement initiative that focuses on collaboration and patient safety so that they can improve birth outcomes through the use of what they call patient safety bundles. These safety bundles are tailored to specific conditions associated with pregnancy and birthing to provide a structure of actionable steps that have been associated with patient outcomes. Currently, Michigan has implemented 4 of these safety bundles. They're specific to conditions around obstetric hemorrhage, severe hypertension in pregnancy, safe reduction of primary cesarean birth. Some folks know that as C-sections. And then postpartum or post-delivery discharge transition. So how we go through that process of now that you've given birth, how do we transition from hospital to home? And one of the last kind of MDHHS focused initiatives that I'm going to highlight today is the MDHHS doula initiative. So a doula is a birthing professional who supports all aspects of a pregnant person. So non-clinical aspects such as emotional, physical, and informational needs. And they're typically in their lives before, during, and after giving birth. Many studies have shown that the use of doula services has been associated with improved birth outcomes. MDHHS has started this doula initiative, which increased access to doula services, specifically through these 3 pieces around Medicaid reimbursement for doula services, as long as they are a part of the doula registry, and then additional referral for services such as these are no longer needed, as you may have needed that in the past. It's been set as a preset standard through our state physician advisory, and then MDHHS has also approved 4 new training programs to increase the number of doulas that are within the state of Michigan. The very last thing I'm going to talk about today is around inclusive language practices. I wanted to touch on this because this is a piece that we all can incorporate. It's really important to create a space that is inclusive of various identities that give birth. As such, incorporating the use of inclusive language when talking about pregnancy, birthing, and other maternal health stages allows those we serve to feel safe and seen Creating a safe and welcoming space is critical for building trust and authentic relationships. Consider adopting phrases such as pregnant people or birthing people as appropriate in your professional personal work. Using that language allows folks to see themselves in these journeys and in these initiatives so that we're already starting at a more welcomed place, and we can have many of these programs be successful through the utilization and strong health outcomes that can occur. Thank you. That is.
Ms. Calloway, thank you for your wonderful and informative presentation. I'm sure we will have questions for you at the end of the next presentation. Next, we are going to hear from Ms. Chandler, who will talk to us about how health centers bring accessible, affordable primary care services to underserved communities in Michigan. We are extremely excited to welcome our last presenter, who will discuss the hands that bring us food, ensuring migratory farm workers feel valued and have access to health care. Please join me in welcoming Ms. Jackie Chandler. She has spent the last decade contributing to the health center movement and bringing accessible, affordable primary care services to underserved communities in Michigan. She's a master's level community health educator by training, and she started off serving as an AmeriCorps member in a community health center in West Michigan. She worked as an outreach specialist at the Michigan Department of Health and Human Services, Michigan State Health Department, and currently works as an integrated health program manager at the Michigan Primary Care Association. The Michigan Primary Care Association is the voice of 40 community health centers and 4 Native American health service providers that provide primary and preventative health care to more than 715,000 patients in rural and urban communities across Michigan. At MPCA, Ms. Chandler advocates for funding and policy that creates timely access to primary and preventive healthcare and healthcare services that reach community members when and where they need primary care. She grew up on a gravel road and mostly shared space with neighboring blueberry fields. In fact, that road is still unpaved. And has a great love and respect for the food grown and processed in Michigan and the hands that bring us that fresh produce. Ms. Chandler, the floor is now yours.
This is Jackie Chandler. Thank you so much, Marissa. Thank you so much to the MDCR for hosting this forum today. And also, I learned some great things from Danielle, so I appreciated being able to listen to her session as well. So I don't know what brought you here today to join. I'm very glad that you are here. What I am sharing with you today, you may know something about. You may have lived experience. Perhaps you've been a farm worker or have had a farm, or you've loved someone who's been a farm worker or has a farm. And some of this will be new information. What I hope you come away with today is more curiosity about others' experience in farm work and what that might look like day to day, and a couple of ways that Michigan can do more of the good things to show we value the hands that bring us food each day. I'm just going to share a little bit about myself just to kind of show how I'm able to access systems in healthcare. I am a white woman. I use she, her pronouns. I'm a millennial. I now have a full-time job with benefits, including health insurance and paid time off so that I can go to my medical appointments. I have access to a smartphone and to good Wi-Fi, and I frequently use telehealth services for my medical or mental health visits. I speak English as my first language, and in all of the years that I've gone to medical providers, I've been able to leave an appointment and feel that somebody was understanding what I was saying, and it was reflected in the care that I received. I also was born in Michigan. and I've lived in different parts of Michigan, but I've been a lifelong Michigander. And I've really come to get to know certain communities around Michigan. And I now live about 20 minutes away from most of my family. So I do have my support system around me. I list out all of those things. Danielle had some wonderful slides showing like social determinants of health and how we might be experiencing things differently. And all that to say that the things that I described about myself, I fit quite well within the system that we have. The system that we have includes me. And even in the ways that I might feel some inconveniences in accessing healthcare, I still have a pretty reliable car. I can get myself to appointments. I have good insurance, so I don't delay care. If I need care, I know I can schedule it, and I got insurance there for me. And so I just walk through those things because these are really the things that we see each and every day in every agricultural season, that those situations are not always available to all of us. And our healthcare systems are not always designed to meet those needs either. So I'm just going to talk a little bit briefly about bias in healthcare. And you're going to notice that all throughout the time that I'm speaking with you, I'm going to use the words migrant or migratory. And these words might bring up some things in you that you may or may not have been aware of, and also in the ways that we use these words. And, you know, when we look at implicit bias or our unconscious bias, it is an attitude or internalized stereotype that affects an individual's perception, action, or decision-making in an unconscious manner and often contributes to the unequal treatment of people based on race, ethnicity, nationality, gender identity, sexual orientation, religion, socioeconomic status, age, disability, or other characteristic. It also contributes to hate crime incidents in the United States. The Department of Justice had some data from 2021. I know we had that PSA earlier that MDCR showed, but there were approximately 10,350 single bias incidents that impacted over 12,000 victims in this country. And I was going to winnow it down to the Michigan data, but really it's important that we look at the United States holistically, because for many of our migratory workers, they're coming to us from Texas or from Florida. So we kind of have to own our data as a country for people's experiences as they move in and out of states and what that experience might be like in their home state or the state that they're visiting, and how they experience discrimination or hate incidents in the communities that they are either temporarily residing in or that they're returning home to. Simply, we all have implicit biases, and unfortunately, it does impact individuals in a real way, and it does show up in our systems of care. For example, I talked a little bit about how I can access care, but if you think about some of our standard healthcare models, clinic hours are rather limited. Some communities may have no reliable transportation services. Practice may offer no medical interpreters. Extensive paperwork might be presented to a patient and they might not have assistance with that paperwork or understanding why it's being collected. There might be no outreach services. Somebody could be temporarily working in Michigan for the agricultural season and not even know that there was a medical clinic that was a mile down the road, right? They don't have the familiarity that I have in growing up and knowing what are the landmarks in my community. Also, healthcare may not have medical legal partnerships in place that they're using. So what does this mean? It means that we have systems of care that are excluding people from care when they need it. And again, just like with implicit bias, it's an unconscious bias. It shows up in us, and it's kind of for us to decide when it boils up to us, what do we do with that information? Do we act on it? Do we think through it? And the same thing as how things show up in our systems of healthcare. Are we just doing things how we've always done them, and that's how we think it's supposed to go? or are we developing systems of care that are responsive to our community members that we're serving? And that's where I'm going to back us up a little bit. And I know Marissa had mentioned in my intro that I'm with the Michigan Primary Care Association, and we talked about community health centers and the health center movement. So what does that actually mean? So when I talk about the health center movement, I'm talking about something that's actually in federal statute, and the health center movement has specific grant making and requirements for providing care to underserved communities. And again, like Marissa had noted, in Michigan, we have 40 community health centers all around the state, upper and lower peninsula, in urban and rural areas. And we have 4 Native American service providers. And again, that's more than 700,000 lives that are being served. And those health centers are in those communities because those communities have a demonstrated need because there's a medical shortage. And really what started a lot of this health center movement, which later consolidated and became a broader umbrella of health centers, first started under the John F. Kennedy administration. So back in 1962, the Migrant Health Act passed, and it initiated the first federally funded primary care program in the United States. And it was a precursor to what we have today and what we call the Community Health Center program. And the Migrant Health Program was aimed to address the disparities in healthcare access experienced by migrant and seasonal farm workers. And it's been over 60 years. We do still have the program, and we still have need for it because, unfortunately, due to the nature of farm work, this is very hard work. It is long hours. When you are in peak season where you need to harvest that crop while it's still viable, you might be working more hours than usual. You might have less time available to you to meet certain appointment times, right? So again, we really have to think about how we design our healthcare programs, and are they really reaching people who are in our communities? Now, one of the things I also want to talk about, I talked about migratory farm worker. And as far as what that actually means, the simplest way to phrase it is that a migratory farm worker is establishing temporary housing to do agricultural work. So it's not like at the end of the day that they can drive 20 minutes and be back at their home. Typically, you are coming to Michigan from a different state, from Mexico. The Department of Labor has the H-2A guest worker program for temporary agricultural work. And over the last couple of years, especially with the pandemic and how that impacted essential workforce, Department of Labor increased the amount of guest worker visas that they grant. And again, most of those guest worker visas are given to Mexican nationals, although we do also see that we have folks who come to Michigan from Haiti. And as an example, they would need assistance with interpretation for Haitian Creole. So really what it means is there's a lot of ways that we have to get creative to get the work done. And the state of Michigan's agricultural sector is one of the largest and most diversified in the country. It practices and it relies on the hard work of migrant and seasonal farm workers each and every year. And that work brings in more than $2.3 billion in farm revenues. So for me, there's value and respect to those hands that feed us and contribute to our economy. And when I say hands, I know that we're kind of in this scary time of figuring out what AI is and what robots can do. And yes, there is very expensive farm equipment out there that does a lot of work and you operate the farm equipment. But at the end of the day, there are still certain crops that you have to still pick by hand. And right before the pandemic, I was able to speak with a farm worker in the northwest part of Michigan who has been coming up to Michigan for farm work since he was a child, and he comes up from Texas. And he was talking to me. I mean, he had so much pride when he was talking about the apples that he picks, and talking about how, you know, there's a particular variety of apples that they have to be really careful with, and how they pick it and how they package it. Because if you're not careful with this variety of apples, it will bruise, and then it's not viable for the market. So that's not exactly something that we can just have a very dexterous and fine motor skilled robot going about and very gingerly picking apples and making sure they're packed very carefully so that they're not bruising. So yes, this is something that we still have a need for humans to also be doing that work. And that these humans are not just another piece of farm equipment, right? They have all sorts of needs. And when we talk about whole person care, we mean how that relates to their physical health, how that relates to their mental health, spiritual health, and your occupational health. There is so much risk in farm work. There's risk of exposure to heat. And not just heat, but humidity. It's that humidity that can really exacerbate heat-related illness. There's also exposure to chemicals and pesticides. There's regular application of those chemicals. And yes, there's a lot of different worker protection programs and education and ways to handle those products. But at the end of the day, you still have that risk of exposure to things that could cause rashes or cause damage to your lungs, or cause other symptoms that would need to be treated in an urgent manner. It's also work that, typically folks are going to report a lot of musculoskeletal pain, back pain. And sometimes the way that people cope with that back pain might be to use substances like alcohol at the end of the day to try to cope with that pain, or they maybe are using another substance because they're not able to, maybe access healthcare in a way to help them cope with the physical toll that the work can take on your body. So there are definitely those occupational health risks. But of course, we're humans, we come with, other things. I mentioned the farm worker that I spoke with before the pandemic, which I did confirm with that health center. He's still coming back, and he came back this year to do, we'll be coming back this year for the apple season as well. But one of the things he remarked on to me was that, he manages his asthma. And when he comes to Michigan, he goes to the same health center, they know each other by name, that he said he has an easier time getting his asthma medication while he's here working in Michigan than he does when he goes back home to Texas. And that's something to think about when you're working strenuously in very hot, peak late summer times to pick apples, and you're being exposed to dust and pollen and other allergens. These are things that can exacerbate your asthma symptoms. And so not having access to, a reliable source of your medications to manage your health could mean somebody ending up in the emergency department. So that's really where primary care can fulfill its role, right? It's making sure that we are that person's medical home, and that folks have a way to either screen and prevent for something, or to manage a chronic condition that they're living with. And that coordination of care is very important too, because when you're moving around, and you're not just moving from country to country or state to state, for a lot of folks who come into Michigan, they'll come in and do their worker orientation and jump right into blueberries. And right as blueberry season is wrapping up, guess what picks up? Apples. So then you've got folks moving across counties to work on a different crop. So again, migratory movement. That does pose an interesting consideration for continuity of care. So that just means we just have to be a bit more creative in how we try to plan for that and work with the patient, which the patient is part of the primary care team. They're the center of the care. Try to figure out ways to make sure that that person is going to have that continuity of care as they move around. So let me just go back to my notes, make sure I'm staying on track and on time. Yeah, so again, I had mentioned before, there are worker protections in place, and there are agencies that our health centers partner with, whether it's Farm Worker Legal Services, or the party partnering with Department of Human Services. There's a lot of different partners that can address different aspects of being a farm worker. The migrant labor housing that they reside in temporarily has to be licensed by LARA, and it has to be inspected each year by MDARD before folks can live in that housing. So there's a lot of different partners in this care. And so really building up your partnerships is very critical in achieving this work, and knowing who's doing outreach and how you can partner. We did see some great instances, for as many things as went wrong during the COVID pandemic, there were some silver linings that we had, and that there was ways that we were really trying to think about how we maximize our impact by working with each other. If we're going to do outreach, hey, can we bring food? Can we bring blankets? Can we get some of that paperwork, intake paperwork done while we're talking with you? So that way, when we come back next week, we can just have you check in, and we can start doing a mobile health visit with you right at your migrant labor housing. So really thinking creatively about that. And, I mentioned migrant labor housing. One of the interesting things is, when that's licensed, typically that's being licensed for the summer months, and they don't license it for the winter months. And there's a reason for that, because some of that housing doesn't have heat. So you're not licensed to have somebody in there, say, in November. But, in Michigan, even in summer months, we can have some cold nights. And so for some of our health centers, some of the things that they hear from farm workers is, hey, we need blankets. We need like a heavier jacket to wear, right? So it's those kinds of things. And I know Danielle talked earlier again about social determinants of health. Well, as farm workers, these are some of the specific conditions that you're either living or working in. And so that's something to be really mindful of. And again, when we think about our partners, the farm worker is our biggest partner, right? The farm worker lets us know what their needs are and how to kind of design our programs around that. We've also found that growers and owners and farmers are often a really important ally. We try to make sure that we are reaching farm workers where they are, their migrant labor housing, which in Michigan, we have it in statute that migrant labor housing that is licensed by LARA, that outreach workers can go to that migrant labor housing and provide services and outreach without permission of the owner. Unfortunately, in the last year, we did have an instance where a health center was at migrant labor housing and was providing mobile medical visits to the farm workers residing there. And the owner came over and yelled at the health center to get off their property, even though the health center actually had a right to be there and the farm workers had a right to receive healthcare. But the situation was escalating, so they had to close down services for the day and leave the property. And that meant having to follow up with local authorities, follow up with Farm Worker Legal Services, follow up with the Department of Labor and Economic Opportunity, so that could be investigated. Because again, we don't want people to be gatekeeping another person's access to healthcare. We want to make sure that somebody can receive the services that they need when they need them. But I also have other scenarios in which the farmer is the biggest advocate for their workers to get healthcare, that they will get on the golf cart and they'll go around and they'll say, hey, it's your turn. I'll bring you back up to the van. And so that way you can get your visit. So again, this is what's possible. There's a lot of scenarios in which things can go well. There's a lot of scenarios in which people can partner together to make sure that the services provided in healthcare are responsive to the needs of farm workers. So I'm getting very close to the end. I just want to give a couple of wrapping up thoughts, and I'm very interested to see how our Q&A goes. But some of the things I just really want to emphasize is the biggest takeaway is, how do we make sure that primary care gets to our migratory farm workers? And part of that too is lived experience is valuable. And in some of our health centers, the folks that are on the team that are doing outreach and mobile visits, they came from a farm worker family. They know what it was like to be a farm worker. And then they found their way into working in healthcare. And that's huge. Also, having bilingual team members is important. We do, our health centers do have language lines that they can use out in the field. If for some reason, somebody needs a language that we don't have a bilingual staff person there who speaks it. And those language lines can be wonderful. Although sometimes the problem is we are going to communities in which bandwidth is not always great. And so that might interrupt some of those language line services. And that could be, a little frustrating, right? So we have some issues there with infrastructure, being able to have better bandwidth in rural communities so that we could see better language lines, better telehealth options, better ways for, folks to connect to the internet, and, better ways for them to connect within, back to families that are living in other communities. So, and also that just kind of goes into, yes, being able to hire bilingual team members, being able to hire team members who have lived experience, but also just being able to hire folks in healthcare right now is so needed. We have health centers that they would love to expand their programs and the reach of their programs, but they just might be kind of stuck right now with a team of 3 to 6 people. And you're just going to do as much as you can do and continue to communicate with your partners and do what you can do. So again, I have so much value and respect to our farm workers that continue to come back to Michigan and continue to prep, tend to, and harvest crops and process them. So that way I can go to the farmer's market or I can go to the grocery store and get access to fresh produce. And I can cook a meal with my husband because that makes my life better. So I appreciate the opportunity to share with you a little bit today. I could talk to you about this all day. I know I only had a little bit of time, but I was happy to be able to share just a little bit of information with you. And I hope that it's given you a little bit more curiosity about how we might do more and what that could look like in Michigan. So that way we could have better agricultural seasons and that we could see better access to care and think about how we work through our biases. Thank you.
Thank you so much for your presentation, Ms. Chandler. I'm sure those listening have learned a lot from your presentation. And I hope that all will keep in mind farm workers and their health when they're shopping for fresh produce, such as asparagus, apples, peaches, etc. Thank you again. So with that said, we're going to move on to the question and answer section of today's program. The presenter shared a lot of great information today, and I want to make sure that the attendees get all their questions addressed. So I'm going to ask the presenters to turn on your cameras and we will begin taking questions. As a quick reminder, please remember to state your name before speaking, and we will now open the floor for questions.
This is Patty speaking. So I have one comment and request in the Q&A and then one question in the chat. So I'll start with the request. And this is for Danielle. So the attendee says that this is really great information to put together in a systemic way. Will we get the slides to your presentation?
This is Danielle. Yeah, I can share them with Marisa, and I'm sure we'll be able to share them with attendees.
Thank you, Danielle. And then my question in the chat is for Danielle, and it is sort of a 3-part question. So it's, how are physicians and our hospitals made aware of the various programs to address disparities? Has there been buy-in? And do we have data on outcomes?
Hey, this is Danielle. Yeah, I would say that many of the hospitals in Michigan are aware specifically of the MyAIM bundles. So a big part of kind of the awareness and buy-in from those programs is part of the Michigan Health and Hospital Association, as well as the regional perinatal quality collaboratives that I mentioned. Many of the quality collaboratives have membership from health systems, and many of the collaboratives also kind of adopted these bundles or identified these bundles based on the current data that they were seeing. So for example, I mentioned the reduction in preventable cesarean deliveries. So, looking at county level data of those deliveries and seeing that this could be something that would be beneficial. So that's kind of how the buy-in has been brought, as well as the awareness. And then in terms of data, a lot of the data that I talked about today is from the maternal mortality and morbidity surveillance group, as well as the fetal infant morbidity mortality review committee. So both of those groups, their roles are to abstract or pull the data related to outcomes, specifically morbidity there, and looking at what has been listed as the cause and categorizing it as such. So there is that data. When it comes to specific patient safety, the outcomes data, much of that you would be able to find on Michigan's website. So that's going to be MIAIM.US. And so there you should be able to find many of a list of the specific hospitals, maybe that are more local to you, if that was something that you were inquiring on. Additionally, I'll list kind of designations, which are identified based on kind of their level of participation within the bundles. So, they score them based on which bundles they've adopted, as well as kind of their adherence to communities of learning that are related to these evidence-based practices. Hopefully that helped.
Thank you, Danielle. So at this time, this is Patty speaking, sorry about that. So at this time, I do not have any other questions in the Q&A or the chat box. Thanks again for your presentations and the information.
I have 2 or 3 questions for Jackie, maybe. The first is, are there opportunities for internships at health centers, and in what positions?
This is Jackie speaking. We do have a number of open candidate positions right now. It might be something I can give my contact information if I knew maybe what part of the state you're in or what part of the state you're interested in being in, and see what opportunities a health center may have. Internships are a really great way to start to understand what you would like to do in healthcare and what you're passionate about. So I'm wondering, perhaps if I maybe could put my email in the chat, it'd be fine if you wanted to reach out to me if you wanted to talk more about it. I think I'd also seen something in the chat related to more information on migrant health. And there's a couple of resources. I mean, if you're looking for like educational or kind of informational things, the National Center for Farmworker Health is a really excellent resource. I can find the link to that and put that into the chat and let you know what that website is. They also host annual conferences. So for today, with 30 minutes, I was like, oh my gosh, how can I organize myself to say just enough? But there's a whole 2.5 day conferences just on migrant health that happen all across the country every year. And I've had the privilege of going to 2 of those conferences. So there's definitely a lot of great educational resources out there. So I think that I could probably first start you off with the National Center for Farm Worker Health, because that's also who they're considered a national organization to provide education and training and technical assistance in that area. And I use their services, and so do our health centers. So let me find that website for a moment. I don't know, Marissa, if you had another question while I find that.
Well, my second question was, who is the key person to refer students to? But you may have answered that by stating that they can contact you, right?
Yeah, I do. This is Jackie again. I do have some other colleagues where, depending on their request, it might be more appropriate for me to connect you with one of my colleagues, but certainly if there are, and definitely, you know, we are trying to get more students in healthcare, and if you have a passion for serving communities, that's how I started. I started off in AmeriCorps, so 10 years later, I'm still doing it. So I think maybe I would be able to put that in the Q&A, my email. Would that work best, Marissa?
I think so. The third question I had, Jackie, is, have you found any language that you haven't been able to find an interpreter for?
So this is Jackie again. I would say that we have had some dialects that are common in parts of Mexico. I would say that I've had, you know, I've known some medical interpreters that they have some familiarity with that dialect, and they can still, you know, do that visit quite successfully. And we actually do have a vendor called Voice that we work with that offers that if any of our health center members are looking to have a new contract with the language line vendor, we work with them. And I have actually checked with that vendor on 3 of the dialects that we do commonly see come to Michigan. And those are dialects that they do provide interpretation and translation services for. So I know certainly when we had a scenario where we had some of our H2A guest workers come over from Haiti, that did give us a need to start translating into Haitian Creole and making sure we were prepared to have those language lines set up, because we did have a group of Haitian workers who were actually very sick, and that it was a good learning scenario for the farmer. They now get on that particular health center schedule every single year proactively, because when your workers are sick, who's going to do the work? So it's sometimes been those scenarios in which we found that really helps to cement a connection of, hey, let's get you on the calendar. We'll make sure we're going to come out right at the beginning of next year orientation and make sure that we can do assessments with your workers. So I don't know if that quite answered your question, Marissa. We definitely have seen scenarios where there's been different dialects used, and we do lift that up to any of our vendors we work with on if they can provide interpreters for those dialects.
No, it has, Jackie. Thank you. Just also checking for MDCR also making sure that all individuals are having a great life here while they're working and living in Michigan. Jackie, I was informed that you can post in the chat.
Oh, great. I will post 2 things. The first thing I'm going to post is the National Center for Farm Worker Health website. So that's ncfh.org. And the second thing that I'm going to post is my email at the MPCA. So it's jchandler@mpca.net. And I think, was that all of the responses you needed?
Yes, I think so. One more time, Patty, do we have any other questions?
This is Patty speaking. There is no other questions in the Q&A or the chat.
Thank you. Is it okay, Jackie and Danielle, if anybody would like to send you a question, is it okay for them to contact you?
This is Danielle. Yes, that's totally fine. I will put my email address in the chat as well. That is calloway@michigan.gov.
Thank
And
you.
This is Jackie. Yes, I'm happy to respond to requests. I might not be the best person, but if I can provide you with some information, I'd be happy to do so or connect you.
Thank you. We're going to wrap up now. Thank you to all our presenters for presenting today. Your expertise and insights are invaluable. Thank you to all our registered participants. We welcome all of you back for our next campaign forum, which is scheduled for Thursday, July 27, 2023, from 1 to 3. The next forum will focus on eliminating hate and bias in public service. Join the Michigan Department of Civil Rights as they discuss recent and proposed changes to civil rights legislation and the impact on service provision by government entities. This year, our Michigan Response to Hate virtual campaign will end with a Michigan Response to Hate conference scheduled for Thursday, September 14, 2023, and it will be from 8 to 3 p.m. at the Kellogg Hotel and Conference Center in East Lansing, Michigan, which will focus on legislating against hate. If you enjoyed today's programming, I hope that you registered to attend the Civil Rights Summit that will be held next Tuesday, June 27, 2023, from 8:30 to 4 at the Suburban Collection Showplace in Novi, Michigan. The focus of that will be the impact of discrimination on health. You can learn more about the Michigan Response to Hate campaign by visiting the Michigan Department of Civil Rights website at www.michigan.gov/MDCR, where you can also explore ways to get involved. Please check out the pledge that is available for download and distribution. And remember, eliminating hate and bias in our state is the responsibility of all of us. Thank you for joining us today.